Well, the ideal of focusing on the people who have diseases, not just the diseases that people have, we all know that ideal. And I think that our sense is the payment system does not necessarily reward that. And I want to go to the payment system next. But do you think, which comes first, the chicken or the egg? Is it in the water and in the culture and the educational values, and then the payment system may just reinforce that? Or is it the other way around? The payment system is where it begins, and that's why it's in the water.
Well, unfortunately, it's the chicken and the egg cycle. It doesn't start in any one place. But the challenges are much different now than they were then, because now we do have these increasing morbidity burdens that aren't this disease plus this disease, but it's the whole constellation of diseases. And fortunately, we're really in a good position now to measure morbidity burden. That's not disease by disease care. We have systems that can say, this subpopulation has got a greater morbidity burden than this population, and it's not because they have more heart disease and they have more rheumatic, that kind of thing. And that is what we should be doing. We should be giving rewards, giving incentives, giving payment to physicians for dealing with the burden of problems they have to deal with. It's not a big trick. We have the tools to do it.
The whole chicken and egg thing also relates to how we're going to solve our problem. For a long time, primary care physicians have been angry at insurers for not paying them enough for all sorts of problems. It's time to stop that. The primary care practices and the insurers have to get together, and there has to be a compact in which the insurer will say, if you do a better job, we'll pay you more. And the primary care practices have to say, we promise to do a better job, but we need to get more payment and different payment.
Well, let's talk about that compact. Define doing a better job. What is the deliverable that we should be ready to go forward with?
Number one, as Barbara said, a primary care practice needs to know who its patients are and needs to be responsible for those patients, and the patients need to know where their home is. Number two, there has to be prompt access. If people have a problem today, they should be able to get that problem taken care of today. And there has to be night call and weekend call so that people don't constantly go to the emergency department when they don't need to go to the emergency department. So access is absolutely critical. And then we have to make sure that our quality is good, that all the preventive and the chronic care needs and as Barbara was saying, the problem that the patient comes to you with is solved.
All right, so we have an idea of what we want as patients and what we would like to provide. How should we get paid for it? Alan, you've thought a lot, you've made specific proposals. Do you want to give your platform?
Well, I think we need to pay for the things that we want. Right now, we pay for things in another way. And the things that we pay for are procedures. And the unit of payment for primary care doctors and those who don't do procedures was the visit. We have to come back, take responsibility for this, and redesign the system so it works for society and it works for patients and it works for the profession. So I think the essential thing is let's stop paying for volume of visits and let's pay for desired outcomes. And those outcomes can be in 3 areas, maybe 4. The first area would be patient access and patient-centeredness, if we want to use that term. That is, how friendly is the care for patients? How accessible is it? How personalized is it? Et cetera. The second area would be in quality of care, and not process. As has been pointed out by people, pay for performance is very often pay for process. And the problem is that the link, as you know, as an expert in this area, between process and outcome is sometimes a leap of faith rather than an evidence-based event. So we want to pay for outcomes. And the kinds of outcomes medically that we're talking about are those outcomes that either are proxies for ultimate outcomes like a hemoglobin A1C or certain level of blood pressure control, or, as Barbara alluded to, even functional status of the patient is a very important outcome. And the third area is in cost effectiveness or cost and quality. So what we envision is let's pay people enough to have the resources to do the job right We look at the payment to the organization, be it a team, an individual, or a larger organization that's going to give us the deliverables. Number two, let's give them a huge incentive to do the right thing, meaning let's give them a bonus. Let's take a large part of their payment, maybe a quarter, and let's give them a bonus on top of the adequate payment to just get started, and give them a payment bonus for doing the right thing. And that is not putting in 16 extra catheters and 14 extra stents, but making sure that their patient's cardiovascular health is now the best it can possibly be. Now, what that sounds like is capitation. And we had this notion of a comprehensive payment for comprehensive care. That was a 1980s concept. But it got distorted, and it got distorted in two ways. One, it was not risk adjusted. And secondly, the only bottom line was the ultimate bottom line of cost. Did you save money? And it had another flaw. The number of dollars that was given in capitation very often was nothing more than the number of dollars in the old payment system given as a lump sum, which were too few in order to do the job right.
What's your take, Kate?
Just as an individual provider, thinking about how I would like to be paid, I would like to be probably half of my salary to be a sort of, in exactly that model where I am paid for the number of patients I have, their age, and how complex they are, just as a lump sum having nothing to do with whether I ever see them. One of the issues is we get paid for visits, and yet the job of a primary care doctor is enormously taken up time-wise by paperwork, completing records, doing prior authorizations, answering phone calls, talking to people, emailing people, so that I would say, since I've been in practice a long time and I have an elderly sick population, that for every hour of face-to-face time, I have another hour at least of time that I spend that's unreimbursed. So if I'm there for 13 hours, I'm getting paid for about 6 of the hours I'm spending. So I do think that there should be a substantial sort of lump of this is what you're being paid to manage these people. I do think that visits could be paid. I think one of the major issues for primary care doctors around the RVU system is it's designed for specialty care and single problems. There is nothing in the RVU system that allows you to take into account the fact that you've just seen somebody with congestive heart failure, hypertension, hyperlipidemia, coronary disease, renal insufficiency, and diabetes. That is a far more complex set of problems. I think pay for performance with outcomes is very important with the following caveat, and this is, I think there has to always be a little wiggle room, because I think all of us who have taken care of complex medical patients who, for example, have hemoglobin A1Cs in the 9s is not necessarily because you're not trying. It's because there are psychosocial issues that lead this patient to, I'm not taking my 60 units of NPH this morning.
We somehow have to encourage medical training institutions to pay for the training of primary care physicians. Right now we're spending about 70 times more on the production of specialists than we are on the production of primary care physicians. That absolutely has to change. We are not going to change anything unless we change the ethos of medical education. And that, I mean, I think is maybe even my top thing, because that's going to change the prestige, that's going to change the financing, it's going to change everything. We just got to get on to something that can be done like that if we had the political will.